Good afternoon. In this session we are going to speak about the obstetric anesthesia and analgesia. First of all, we will speak about the anatomical and physiological changes, the role of the placenta, the effects of the pregnancy of maternal body, the pain relief, cesarean section anesthesia, and the emergencies in obstetric anesthesia. First of all, we should mention which changes happened in the respiratory system. The mucosal edema of the upper airway is enlarged the tongue and the epiglottis, increasing the breath size that make the intubation is difficult. Mucosal edema worsens in the presence of preeclampsia. On the other hand, the tidal volume is increased close to 40%. The respiratory rate is also increased, and the functional residual capacity is decreased further in supine, so the oxygen consumption is increased close to 60%, so it's a high risk of hypoxemia in this situation. In this situation, we should know that smaller size endotracheal tubes are used. Pre-oxygenization is essential. As soon as possible, we should start it, and we have to maintain the normal lower level of carbon dioxide during the mechanical ventilation to not change the pH level. Also, reduce the compliance as higher airway pressure needed for the adequate ventilation. During the anesthesia in the respiratory system, we should know as smaller manipulation can cause respiratory edema that can be fatal sometimes. So, we would like to intubate these patients, the most experienced should do it. On the other hand, in the case of the cardiovascular system, also remarkable changes occur. Cardiac output is elevated. At the end of the first trimester, it's close to 40%, peaking immediately after delivery. Heart rate is also elevated. On the EKG, PR and QT interval is shortening, the SZTE depressions can be found, and the deviation of the axis to the left side can be found also. What is more, systematic vascular resistance is decreased. The diastolic pressure decreased 20%, and the systolic pressure also decreased as 8%. And in the 1930s was first recorded the aorta caval compression. The graviduterus rests on the aorta, on the vena cava inferior, after the 12th gestation week, so the uteroplacental blood flow is not autoregulated. The placental blood supply may be compromised. Lateral tilt position should be employed. So in this diagram it shows that the caval compression occurring that decrease the preload to the heart, make the heart running without any blood. So That's a very serious situation that can be easily cured by the left tilt position. Also, gastric function is altered. Easy to mention the morning sickness, the hyperemesis gravidarium, which are related not only the gastric but also the brain function, but the relaxation of the lower esophageal sphincter can be found, and in an intragastric pressure elevation that can be the risk as the gastric regurgitation, and that can be fatal as causing acid aspiration as later described by Mendelssohn. So in every situation, if we should intubate, plasma volume is elevated up to 50% by the term. The red cell volume also increased, but only as 30%, and these all led to the physiological anemia of the pregnancy. That led the relative low level of coagulation factors, and also hypercoagulable states can be occur. The plasma protein concentration is reduced, the colloid oncotic pressure is decreased, that can be led to the edema, the low level of the albumin, the protein binding change the pharmacokinetics. The cholinesterase level is decreased, so the succinylmetonium is slightly prolonged during the intubation, make prolonged duration of the action. The thyroxine glands are hypertrophied, free hormone level is not changed, but the level of the parathormone is decreased, but the ionized calcium level remains constant. The principal hormone of the pregnancy is progesterone and also oxytocin, which make the memory loss during the renal blood flow is elevated as sometimes 75% by the term. The glomerular filtration rate is also elevated. The clearance of the urea and uric acid and creatinine is increased. The urea and creatinine plasma concentration is decreased. We must not forget the importance of the placenta. It's got endocrine function as well as somatotropin hormones, estrogens, relaxin, and progesterones are produced. These organs transfer the products and immunoglobulins and drugs to the fetus, and also it's a lipophilic, non-ionized, unboundedly diffused barrier. The production of these factors is important because widespread relaxation of the ligaments, the widening and the increased mobility of the pubis and the sacroiliac joint to allow passage of the fetus through the birth canal is important. On the next step of the lesson, we should speak about the pain and the pain relief. As previously described, pain is an unpleasant, subjective, emotional and sensory experience associated with potential tissue damage. But in simple terms, pain is what hurts. During labor, in the first stage, uterus and the cervical contraction, the unmyelinated C fibers give the information. In the second stage, the direct pressure of the lumbosacral plexus causes neuropathic pain, vaginal and perineum stretching, and the A delta fibers take an important role of this information projection to the sacral part of the vertebral spine. So, in addition to having an unpleasant emotional impact, pain has undesirable physiological effects also, making hyperventilation, respiratory alkalosis. The ODC is shifted to the left side. The cardiac output is elevated, altered hormonal production, and delay the gastric emptying and make the intestinal peristalsis lowered. So, these highlight the importance of the pain relief. In the 19th century, the first obstetric general anesthesia was made by ether. Queen Victoria's child delivered under chloroform. In Russia, invented the laughing gas, and only in the 20th century was morphine. The first effective regional anesthetic block during labor was presented in 1930s, and a bit later the previously mentioned Mendelssohn described the acid aspiration syndrome under general anesthesia for the cesarean section. More than 70 years, a continuous lumbar epidural block was presented, and the pain alteration by the psychoprophylaxis was presented. And in the 1961, Selig showed that the cricket pressure could decrease. There are many alternative ways how can we decrease the pain. For example, hypnosis, as 25% of the women are suitable for that. On the other hand, there is TENS and acupuncture, as TENS is in the early 1980s, fibers are stimulated by electrical stimulation, preventing the transmission of afferent nexus stimulus from the C fibers, and the electric stimulus increase the endorphins. Also, inhalation analgesia is presented by isoflurane and Antonox as the laughing gas, and the self-administration of these laughing gas should not be below at 50%. The systematic opiates are a good choice, but morphine twilight sleep as analgesia, amnesia without loss of the consciousness is really rare, and these drugs can be found in the maternal milk also. So the peripheral infiltration of the paracervical and pudendal nerve block and epidural subarachnoidal administration of local anesthetics also good choices to reduce the pain. So how can we describe the ideal analgesic drug? So it has a rapid onset, an excellent pain relief in both first and second stages, no risk or side effects to the mother or also the fetus, and the mother be independent during the labor. So it's not easy to mention as no ideal analgesia at the present time exists. Also, nowadays it seems to be as most closely approached by the epidural techniques as well. During epidural anesthesia, we insert a special needle, a chewy needle, to the epidural space, which is mostly contained fat, and it's a virtual space. Identifying the proper position of the superior aspect of the iliac crest can help to identify the proper location of the needle, and we should really use a loss of resistance syringe as identifying the space. Reversible blocks to the transmission of the nerve pulses made by the local anesthetics, for example, lidocaine or bupivacaine or other amide-like anesthetics. These local anesthetics has a special aromatic ring and terminal amine, which can be lipophilic and hydrophilic proportion of the molecule. The local anesthetics block the sodium transport that make the membranes the cell membranes is depolarized, so decrease the input of the information. In Hungary, we are used mainly lidocaine, bupivacaine, and ropivacaine. It has more than an hour onset, but we should know the proper dose and the dose onset of these drugs. So, which are the indication of the epidural analgesia? For example, the maternal request. It is the easiest way. The expectation of the operative delivery. Or maternal disease as cardiovascular or severe respiratory or neurologic disease can lead to us as used epidural analgesia. On the other hand, general anesthesia may be hazardous in obesity, and also indication are the intracranial or arteriovenous malformation, the preeclampsia, or it's a multiple pregnancy. On the other, well, contraindications are the maternal refusal. The true allergy to amide local anesthetics is rare, but sometimes the allergy is occurs, so that's also a kind of contraindication. The more probably is the local infection of the injection point, the uncorrected hypovolemia, and mainly the coagulopathy. Low platelet level or elevated in ENR and LVH treatment make difficult and really hazardous, as there is sometimes after injecting the needle there is a vertebral hematome and direct lesion of the spinal cord, and that can be led to serious. So what is the technique? Mask, gloves, gowns, skins, sterilization. We use sterile techniques as required. May need an EV access if any problem is occur, we need to treat it. So positioning the patient, sitting or full lateral position, infiltrating the skin, identify the puncture site in the lumbar 3-4 or lumbar 2-3 vertebral sites, locate the epidural space with the loss of resistance syringe to saline in the 3 needle. After that, we should introduce a catheter into the epidural place. We should check as there is blood or spinal fluids, and we should give test dose as 2 milliliter lidocaine. In the test, we are looking for paresthesia and other complication or motor blocks. So in this patient, we can show that these are the two needle, the special loss of resistance syringe, the canal which is inserted to the proper place, and the special connection point with a filter. After we have in a proper position the epidural set, we should top up it as making large bolus local anesthetics to reduce the pain, or making or using continuous infusion of ropivacaine and the fentanyl mixture, or bupivacaine and also fentanyl mixture, and we can create a walking epidural as an effective analgesia with minimal motor block during the labor. So in this picture it showed that after skin sterilization, inserting a needle, then through the needle we insert the canal. The most common complication of the epidural set is the poorly functioning global, partial, as unilateral, missed segment, back pain, extensive, patchy, asymmetrical, or sometimes that can cause Horner syndrome. The other most frequent problem or complication is the hypotension, or we can create subdural block or total spinal block, which can be really scary, and it's a really big mistake as an accidental intravenous injection of the local anesthetics. For example, lidocaine is used as an antiarrhythmic drug in cardiology, but bupivacaine is direct cardiotoxic also, that can the CPR ineffective. So it's a really bad thing, I think. And dural puncture as well is a rare complication of the epidural anesthesia, as blood pletching or bed rest and paracetamol and fluid intake is administered. In my knowledge, there is 4 classification of the cesarean section. There is an emergency, as immediate threat to the life of the mother or the fetus. And the urgent is the maternal or fetal compromise that is not immediate life-threatening. Scheduled as no maternal or fetal compromise but needs early delivery, and the other one is the elective, when the delivery time to suit mother and the staff also. There is 2 types of anesthesia for the cesarean section. One of them is general and the other is the regional anesthesia. Epidural, spinal, combined blocks. These are safety for the mother and also safe for the fetal. And regional anesthesia routine for the doctors, but rarely for the mothers. In the epidural anesthesia, the indication in the cesarean section is same as the labor, but easier if already had an epidural set of the woman, and this is caused by, for example, she had a specific disease, for example, arteriovenous malformation or neurologic disease. The technique is the same. The position is also same as the spinal anesthesia or the other, as reduce the caval dysfunction, as left lateral tilt. We should give her fluids, oxygen, and monitoring her heart rate and blood pressure. And after the test dose, we should administer the 5 or 7 milliliter bolus local anesthetics. We should also check the cold sensation on the thorax, on the mammillary line, as well as other motor blocks. The other way to pain relief during cesarean section is the spinal anesthesia. Most commonly used, rapid onset, dense block, but making many times hypotension. technique is as the lumbar 3-4 segment, injecting a pencil point needle in a sitting or lateral position, 2 or 3 milliliter hyperbaric bupivacaine, and that can be another type of needle applied, and that can be most frequently used, and it's sometimes more easier and faster than the epidural. The other way is the general anesthesia, but it's mainly in the emergency situation, or refused or the contraindicated or failed regional anesthesia are mostly the indication. In every time, not only in general anesthesia, also in regional anesthesia, antacid prophylaxis monitoring, pre-oxygenization, and the lateral tilt position is essential. On the other hand, in the general anesthesia, we should use RSI, the rapid sequence induction or intubation, as the gastric emptying is lowered, so that if we not use the RSI, making the chance that the aspiration more elevated. So we use mainly propofol and suxametonium or rocuronium as a non-depolarization or depolarizing muscle relaxant, and after the induction we insert the tube with a special laryngoscope or without laryngoscope sometimes. After the delivery we administered opioid and antibiotics as well. So we have to speak about the importance of the antacid prophylaxis, as fluid aspiration can cause chemical pneumonitis. Giving the woman metoclopramide or ranitidine or and sodium citrate immediately before the surgery can reduce the risk of the aspiration. In the emergency situation, we also give the same but another dose. There are many emergency cases, but one of them is the massive hemorrhage. For example, placental abruption, placenta previa or accerta, or the uterine rupture or atonia can cause a massive hemorrhage. In this situation, it is important to have two large canals, and after we realize the problem, we should give fluids and, if it's possible, blood products. For example, if we don't know the blood type, group O RH negative blood, we should correct the coagulopathies as giving tranexamazide and make the fibrinolysis lower, and giving blood products as Bariplex and other to reduce the risk of the hemorrhage, as giving factors that can be used to the coagulation, and start invasive monitoring as insert an arterial canal, and so on and so on. And if it is required, we should find an ICU or a high dependency unit for the postoperative care. The other emergency cases we should mention is the amniotic fluid embolization. It has a really high mortality because the anaphylactic response to the fetal tissue is occurring during the labor. The signs are specific: the right heart failure, the hypoxia, acidosis, pulmonary edema, cyanosis, and cardiac arrest are the main. But there is no clear treatment. The treatment is also supportive, as the airway, breathing, circulation guideline, the coagulopathy correction, and these women should be as soon as possible transferred to the ICU. The eclampsia is the other case, as pre-eclampsia up to 8% of the pregnancies exist. The endothelial dysfunction, the hypertension, is occur after the 12 weeks and 20 weeks, and one or more organ system is involved. The therapy is mainly the blood pressure control, but the most effective therapy is the end of the pregnancy. So hypertensive disease of the pregnancy are one of the most common direct cause of maternal death in the developed countries. The mercury sphygmomanometer is the gold standard for the blood pressure measurement. There are many risk factors, for example, diabetes, obesity, advanced age, the nulliparity, family history of preeclampsia, antiphospholipid antibodies, autoimmune disease, and so on and so on. So we should have to control the blood pressure as soon as possible and deliver them to the ICU. In the obstetric, anesthesia is the other emergency cases is, for example, the HELP syndrome, hemolysis, elevated liver enzymes, epigastric and right upper abdominal pain, hepatic rupture, platelet count decreases, and hypertension, proteinuria, nausea and vomiting are the most common features. The therapy is mainly the delivery as soon as possible. And we have to speak also, in this case, the maternal about the maternal CPR, as there is many cases: hemorrhage, amniotic fluid, pulmonary embolization, intracranial hemorrhage, and so on and so on. And the most important is, as after the 20th week, gestation must be left lateral tilt. The other is the same as in other CPR. First, we should realize the problem, and as soon as possible, we should start the CPR. And after arriving the ALS group, the intubation as quickly as possible should be applied. So, thank you very much for your attention.